A hearty welcome to one and all present over here. Today, I, Dr. Anubi Kumar, Professor in Index Nursing College. Today, I am going to take the class on Placenta Previa. Firstly, let's deal with the definition of Placenta Previa. So, Placenta Previa is implanted in the lower uterine segment such that is completely or partially covered the cervix or is close enough to the cervix to cause bleeding when the cervix is dilated or the lower uterine segment ephesus. So, this definition was given by the Hull and Resnick in the year 2009. In this, what happens is that placenta previa, it has been implanted in the lower uterine segment, due to which it is completely or partially covers the cervix, and due to which there is bleeding when the cervix is dilated in the lower uterine segment. As per DC Datta, the definition of placenta previa, here in the two pictures you can see one is normal and the second one is the placenta previa picture. So in the normal one, you can see the placenta is marginally placed, but here in the second pic, we can see that the placenta in the placenta previa, the placenta is covered in the lower uterine os. So as per the definition, the placenta is implanted partially or completely over the lower uterine segment. It is over or adjacent to the internal os, and it is known as placenta previa. This definition is given in the book DC Datta. In this picture, it is clearly visible how the placenta is being covered. Here, as you can see, the baby is lying, and in the os area, the placenta is covered, due to which what happens is that whenever the baby is getting delivered, first the head is coming out. But what happens when the placenta is being planted over the os, so due to the pressure of the head exerted by the baby during the labor, and due to many other reasons, there is a bleeding that occurs. Because of that, this condition is known as placenta previa. Now, what all are the incidents of placenta previa? In 80% case, it is found in multiparous women. The incidence is increased beyond the age of 35 with the high parity order pregnancy and in multiple pregnancy. And the incidence approximately it is for 4 to 5 per 1000 pregnancies. So let's go through the incidence again. 80% cases it is found in the multiparous woman, because if the previous delivery, if it was been a cesarean section or something else, so there are chances that the placenta is implanted in that particular area. Second, the incidence is high beyond the age of 35, because as the age advances, there are many multiple problems that arises in the female body, due to which this continues. Then it is incidence is approximately in 4 to 5,000 pregnancies. The incidence increases, and there are cases that in per 1000 pregnancies that there may be 4 to 5 if this incidence occurs. So what all are the risk factors of placenta previa? First one is multiparity. Multiparity means when the female has delivered more than 2 times. Increased maternal age, when the female's age advances above 35 years of age. There are increases chances of placenta previa. Third one is higher altitude. Higher altitude means when the female is living in high altitude area. This is not properly explained, but yes, it can be considered that due to the gravitational pull, the placenta is implanted in the os area. Then fourth point is higher history of previous scar in the uterus. As for the first pregnancy, if the female has conceived and the baby was delivered by the cesarean section, so there may be a scar in the uterus, and due to which what happens is that in the next pregnancy also, when the placenta is getting implanted, it gets implanted in the scar region, and because of that what happens again, there is a reason of placenta previa. And last one is smoking. Smoking is also a factor which leads to placenta previa. Now let's deal with the definition of placenta previa. There are basically 4 types of placenta previa: type 1, type 2, type 3 and type 4. In this picture, it is clearly visible what are the different types of placenta previa. Here you can see type 1 and type 2, it comes under the mild degree. Then type 3, type 4, it comes under the major degree. In type 1 placenta previa, you can see that the os is visible, and the placenta has placenta has not covered the os. In the second one also you can see that the os is visible. This is called as mild degree placenta previa, because here the os is clearly visible and there are chances of normal pregnancy. Here the bleeding will also be not that much. In type 3 placenta previa, here you can see is that the os is covered. The os is covered, but some space is left. And in type 4, you can see that os is completely covered. There is no space at all. So this comes under the major degree. This is type 3 and type 4. So the type 1 is known as low lying, the type 2 is considered as the marginal, the type 3 is incomplete or partial central, and the type 4 is known as the central or the total. So there are 4 types of placenta previa depending on the degree of extension of placenta to the lower uterine segment. So dealing with the first type of placenta previa, that one is the low line. In the major part of the placenta is attached to the upper segment and only the lower margin encroaches onto the lower segment but not to the os. Here it is low line but it is attached to the upper segment only and the lower margin to the but not to the os. In type 2 marginal, what happens here is that in marginal, the placenta reaches the margin of the internal os but it does not cover it. In type 3, that is incomplete or partial center, the placenta covers the internal os. It is partially covers the internal os when it is closed but does not entirely. So when it is fully dilated. Then comes the type 4, that is central or the total. The central placenta covers the internal os even when it is fully dilated. Here you can see that it is completely covering the full os of the female. Now degrees of placenta previa, type 1, type 2, type 3 and type 4, which I have already dealt. So the type 1 and type 2 comes under the mild degree and type 3 and type 4 considers as the major degree. Now what all are the clinical features of placenta previa? Let's deal with the symptoms of. First symptoms that comes is the vaginal bleeding. Due to any pressure that is exerted by the head of the baby or the fetus, what happens is that there is a pressure and due to which their bleeding occurs. So the vaginal bleeding, how does the vaginal bleeding shows over here? First one is it is sudden in onset and it is painless. Here the vaginal bleeding, it is sudden and it is not painful. It is painless bleeding. So the woman may be, whenever she goes to the washroom or anything, she can feel that the blood is coming, but this blood is painless. Second, it is revealed bleeding. Here the bleeding is revealed. It is not been collected in the uterus. Here the bleeding is revealed, because of which what happens is that the fresh blood comes out. The third point, it is bright red and dark color. The bleeding over here is bright red and dark color. And fourth, it is unrelated to activity. Unrelated to activity means here the woman doesn't need to do any activity or anything. The placenta bleeding occurs by itself only. So here the woman is not responsible for any kind of bleeding or something. Next, what are the general conditions? So general conditions of placenta previa is anemia is being there. Why? As the blood loss is there, due to which what happens is that anemia is one of the major cause in this disease. So in the abdominal examination, what we find out is that the size of the uterus. The size over here, the uterus, it feels relaxed and it is soft. Here the uterus is relaxed and soft. The head is floating in contrast to the period of gestation. Why the head is floating over here? Because in the lower part placenta placenta has taken place, because of which what happens, the head is not getting engaged. Then fetal heart sound is usually present. Here although bleeding is there, but still we can hear the fetal heart sound. And then through vaginal inspection, it can find out that the placenta is felt in the lower segment. What all are the complications of placenta previa? So the complications of placenta previa depends upon two: maternal complication and fetal complication. So in maternal complication, there are various complications that occurs during pregnancy, during labor and during puerperium, and fetal complication. So what all are the maternal complications? Let's deal it one by one. During pregnancy comes the antepartum hemorrhage. When the female has conceived and during her antenatal period, antepartum hemorrhage is one of the major causes. In antepartum hemorrhage, what happens is that due to any pressure that has been exerted from the head of the baby, the bleeding occurs. And the bleeding occurs due to which what happens, anemia and various blood related blood coagulation or blood loss happens, and due to which what happens, there is low HB level in the female. So one of the causes antepartum hemorrhage. Second is malpresentation. As the placenta is placed in the lower uterine segment, so there are chances of malpresentation of the fetus. Why? Because here the baby cannot pass. and the baby gets stuck in the lower uterine os. Because of it, what happens is that malpresentation is one of the major causes in placenta previa. And the third one is premature labor. Premature labor is also a cause of placenta previa, because due to as the female cannot deliver out in a normal way, so there are chances that the baby has can be delivered in a premature way. And because why? Because if any in any of the scenario, if bleeding occurs, so there are not we don't have any other option, but we have to deliver the baby in premature labor. During labor, what all things happens? First point is early rupture of membranes. The membranes gets rupture in early way. Second, cord prolapse due to placenta previa. As a cord can get out and baby's head cannot be come out due to this insufficiency of the space, because of which what happens, cord prolapse is one causes that occurs in placenta previa. The third one is slow dilatation of the cervix from the pressure exerted by the head of the baby. If the pressure is more, the dilatation will be more. But as the placenta is placed in the lower uterine segment, because of that, what happens is that proper pressure is not being exerted, and because of which what happens, slow dilatation of the cervix occurs. Then comes intrapartum hemorrhage. During labor also bleeding occurs. Third case is purpurium. Purpurium means after the labor. So in purpurium, what happens is postpartum hemorrhage. Purpurium postpartum hemorrhage is one of the major causes, as due to any of the reasons, XYZ, any of the reasons, there are chances that bleeding occurs. Bleeding occurs due to the injury in the lower uterine segment, the cervical area, or due to the extra pressure that has been administered, or due to any of the things. Postpartum hemorrhage is one of the major causes. Second one is retained placenta. Placenta's bits are being retained in the uterus, due to which bleeding occurs. And third comes subinvolution. Subinvolution means when the organs go back into its normal size and shape. And due to this placenta previa condition, the problem is that the body's organs doesn't reinvolute to its normal space, and due to which subinvolution occurs. In fetal complications, what all happens in fetal complications? Low birth weight babies, as we have already discussed, that there are chances of preterm labor, and due to preterm labor, what happens is that the baby is not developed properly, and due to which low birth weight babies is one of the concern for placenta previa. Second one is asphyxia. The fetus get also been stuck, and due to which asphyxia is also a cause. And the third one is intrauterine death. As the placenta, because of the placenta previa, the head does not gets out, as the proper pressure is not being exerted, and due to the placenta also, their proper pressure is also not exerted. And if the female is in a proper space, like in the urban area, we can easily shift the female to the hospital where cesarean section can be done. But in the remote areas, in the rural areas and all, it has not been yet been identified whether it is a placenta previa cases and not. And when the labor pain starts, it is very difficult for the female to bear the pain, and as because of the labor pain, proper pressure is also not being exerted. Bleeding also occurs due to placenta previa. And if the family members get late due to any of the causes, then there are chances of intrauterine death also of the baby. Now, how we can diagnose placenta previa? First one is placentography. Placentography, here what we can do is sonography. So sonography, we can find out where the placenta is placed. Second is color Doppler flow study. Third is magnetic resonance. And fourth is vaginal examination. So through these examinations of diagnosis, we can find out where the placenta is being placed, whether it is grade 1, grade 2, grade 3 or grade 4. What all are the management of placenta previa? First management of placenta previa is prevention, then comes immediate management, then comes expected management, active management and nursing management. So let's deal the topic one by one. Firstly, dealing with the prevention. How we can prevent placenta previa? First one is to minimize the risk. The following guidelines are used. How we can find out? Firstly, adequate antenatal care. As I already told, when the female is in a rural urban area, it is easily accessible for the female and her family members to take her to the clinics and to the hospitals and to take care of her. That if it is in the rural area, it is difficult for the female. for the easy accessibility. So throughout the antenatal care, adequate care should be given, and when the antenatal care, we can find out where the placenta is being implanted. So in the antenatal care itself, we can find out that yes, the placenta is implanted in the lower uterine segment, so proper care has to be taken for that female. Second is significance of warning hemorrhage. If the bleeding occurs, then it is a warning symbol. We have to find out what are the symptoms and how much blood loss has been there. So it is very important for the significance of warning hemorrhage. If the female is at home and if the bleeding occurs, what all the things we can do. At home, we can put the patient on bed. It is important we can put the patient on bed. Second one is abdominal examination. Through abdominal examination, we can find out that where the placenta is being implanted, where it is being seen, and we can find out that all things. Then comes vaginal examination. Vaginal examination must not be done. Why vaginal examination is not be done? Because the placenta is placed in the lower uterine segment, and due to which what happens if we do any sort of vaginal examination, there are chances of bleeding, and which may again worsen the condition of the female. And we have to transfer her to the hospital. We should not keep the patient at home. As soon as the bleeding starts and if she is pregnant, she has to be transferred to the hospital and admission should be done. Immediate attention. What immediate attention we can do? To ensure an adequate blood supply to a woman and fetus, place the woman immediately on bed rest in a side-lying position. So the female should be kept in a bed rest in a sideline position. A large bore IV cannula is sited and infusion of normal saline. Infusion of normal saline should be done. Then gentle abdominal palpation should be done. What all are the scheme of management? All antepartum hemorrhage patients are to be admitted. So if the patient we find out that she is having antepartum hemorrhage, she has to be admitted. So what all are the points that we have to keep in mind? First one is general and abdominal examination. As soon as we see the patient, we can find out through her general appearance how she is looking, how much blood loss has been there, if she is looking pale and all. Through general examination we can find out. And the second is by abdominal examination. Through abdominal examination also we can find out where the placenta is being placed. Second, clinical assessment of blood loss. We have to identify that how much blood loss has been there. This we can do by doing the HB test. Through HB test we can find out that how much blood loss has been done, how much hemoglobin is left in our body. Then resuscitation if necessary. If the female's condition is poor and if her scoring is low, resuscitate her if she is not being able to cope up. Then localization of the patient of placenta. These all are the 4 basic points that we have to do as soon as we get the patient from antepartum hemorrhage. Then this is again divided into 2 parts. First is expected management, second is active inference. What all are the expected management over here? In expected treatment is carried up to 37 weeks. So what comes in the aim of expected treatment? The aim is to continue pregnancy for fetal maturity without compromising the maternal health. If the pregnancy can be continued, so this has to be continued. This is continued up to 37 weeks. Why? Because total fetal maturity can be achieved. So we can do, and here only when will do that much only if it is not compromising the maternal health. If the maternal health is being compromised, we won't do the expected management. So what all are the indications when we can do expected management? When there is no active bleeding, there we can do it. When the patient is stable hemodynamically, means not that much blood loss has been there, then we can do. When the FHS, fetal heart sound, it is good, and in the CTG, it is a reactive fetus. Only when these indications are there, when there is no blood loss, patient is stable, FHS is good, and CTG has a reactive fetus, then only we will go for expected management, where the treatment is carried up for 37 weeks. Otherwise, we won't go for the expected management. What all are the interventions in expected management? First one is bed rest. The female should be kept in bed rest. Second, periodic inspection of the vulva pads. In the vulval pads, we will inspect that how much blood loss has been there. If it is more, then supplementary hematamics is being given to the patient if the patient is anemic. Then use of tocolytics and RH immunoglobulins to all RH negative mother. RH is another topic that we will deal in some of the other classes. So if RH immunoglobulins has been there, then if RH negative women is been there, RH immunoglobulins should be supplied. What comes in the active management? What In the active management, the indications are bleeding occurs at or after 37 weeks of pregnancy, when the patient is in labor, when the FHS is absent. Here the fetal heart sound is absent, and gross fetal malformation is been there, and the baby is dead, or the fetus is dead. So here we'll go for active management. So in active management, we are having two types. That the first one is vaginal delivery and the second is cesarean delivery. If the placental edge is within 2 cm from the internal os, in this case, no internal examination is performed and cesarean section is considered as the best choice. So here for the placental edge is within the 2 cm, so there no internal examination is considered, and directly it is we are taking the female to the cesarean section only, as it is considered as the best choice. If the placental edge is 2 to 3 centimeter away from the internal os, then what we can do? Firstly, we will do the internal examination in OT. Here also the female is being taken into the OT itself. In this, firstly what we are doing, internal examination in the OT. In internal examination, we are doing artificial rupture of membrane. ARM stands for artificial rupture of membrane, with or without oxytocin, either with oxytocin or without oxytocin. And after the ARM, if we find out that the satisfactory progress of labor, if the labor is progressing satisfactory, we will go for the vaginal delivery. And if we find out that the bleeding continues and there is no labor initiation, then we will go for cesarean section. So I hope this point is clear. We'll take her to the OT. We will do artificial rupture of membrane. If satisfactory process of labor occurs, we'll go for vaginal delivery. And if the bleeding continues and if there is no labor initiation, we go to the cesarean section. So what all are the nursing management that we have to do? As we all know that nursing management is an important thing in nursing field. So in C, first is nursing diagnosis. Decreased cardiac output related to blood loss as manifested by increase in heart rate. So, due to blood loss, there is decreased cardiac output, and because due to which what happens, there is increased heart rate. So, as the blood loss has been there, cardiac output is decreased and there is increased heart rate. So, what are the intervention? Monitor IV sign. In IV, monitor vital sign. In vital sign, we will go for respiration, temperature, pulse, and we will find out what is the vital sign of the lady. Second, we provide adequate rest. We will just lie down the patient in a sideline position, then reposition the client. We will give proper position to the client, that is a sideline position. Encourage relaxation techniques with her, elevate HB of the client, and encourage use of relaxation techniques. So through what all things, if the female feel relaxed, we will do that thing. Then comes ineffective tissue perfusion related to decrease in hemoglobin in blood as manifested by dyspnea. So here the due to dyspnea, so what all things we will do? Here the intervention is monitor vital signs. Vital signs again is being monitored. Encourage quiet and restful environment. Encourage use of relaxation techniques and provide supplemental oxygen to the client as prescribed by the physician. Deficit fluid volume related to blood loss as manifested by vital sign changes. So what we will do if the fluid volume is deficit? Intervention here is monitor vital signs, monitor fetal heart rate, fetal heart rate, then initiate IV fluids as ordered by the physician and place the patient in the left lateral position. Next comes the diagnosis is fear related to outcome of pregnancy as manifested by facial expression of the mother. So the nursing intervention over here is assess the fetal heart sound and make her also listen the fetal heart sound. Allow the mother to share her feelings. If she is feeling any sort of tension, if she is feeling any sort of guilty or anxiety or anything, let her share the feelings. Answer the mother's question honestly. You should be honest in answering the questions of the mother. Include the mother in planning of the care plan of both the mother and the baby. So here the mother should also be included in planning for the care plan of both the mother and the baby. So like this, I have completed the class on placenta previa. In this class, I have dealt with what is placenta previa, what are the various types of placenta previa, what is the various degrees of placenta previa, what all management we can do in placenta previa. Then comes with the nursing management, and like this, the placenta previa topic is completed. I hope this class is clear to one and all. Thank you for your patient listening.